Pharmacology SAQ 17 Heparin. A. Describe the mechanisms of action and side effects of heparin. Mechanism of action. Unfractionated heparin. These are 15 to 20 kDa anionic, highly sulfated, acidic and carboxylated glycosaminoglycans. Unfractionated heparin complexes with antithrombin 3 to enhance rate of factor 2A and AT3 and factor 10A AT3 complex formation by 1000 to 10,000 times to inhibit factor 10A and factor 2A. Unfractionated heparin anti-10A to anti-2A activity is 1:1. UFH also inhibits factor 7A, factor 9A, factor 11A, and factor 12A as heparin concentrations rise. There is reduced platelet aggregation by fibrin at high concentrations of heparin. Heparin reduces plasma triglyceride levels due to the release of a lipoprotein lipase from tissues, which reduces plasma turbidity. Low molecular weight heparin are less than 5.4 kDa and ionic, highly acidic and carboxylated glycosaminoglycans. They also bind to and potentiate the effects of AT3. Their shorter chain more selectively inhibits factor 10A than factor 2A, with the anti-10A to anti-2A activity of about 3:1. Low molecular weight heparins do not affect platelet aggregation. Fondaparinux selectively binds AT3 and potentiates its inhibitory actions on factor 10A by 300 times. It is a synthetic heparin pentasaccharide with a sequence identical to and found in heparin. It's a pure compound with molecular weight of 1728 Da. Selectivity to factor 10A is due to presence of a pentasaccharide sequence in unfractionated heparin, and this is reproduced in the lab to form fondaparinux. Fonda has no actions against factor 2A or platelets. Side effects of heparin. Hemorrhage. This is the most common side effect and is due to relative overdose. Risk is 1 to 5% if therapeutic anticoagulation. The patient may present with peptic ulcer bleed, hemorrhagic stroke, or bleeding in other areas. Cessation of heparin infusion is usually adequate as treatment, as heparin's half-life is about 90 minutes. Reversal with protamine can be considered. 1 mg of protamine reverses 100 units of UFH still circulating, and protamine neutralizes 60% of low molecular weight heparin activity. Fondaparinux is not affected by protamine, and reversal of fonda is with prothrombin complex concentrate 20 units per kg or Novo 7 90 micrograms per kg. Next complication is heparin-induced thrombocytopenia. Risk is 1 in 200 therapeutic doses or 1 in 10,000 prophylactic doses, with unfractionated heparin having higher incidence compared to low molecular weight heparin. 95 to 99% are type 1 HIT, and only 1 to 5% are type 2 heparin-induced thrombocytopenia. In type 1 HIT, there is no thrombosis, platelet count reduces slightly, lowest is 100 times 10 to the power of 9 per liter within 3 days, and returns to normal platelet count if heparin is continued. Incidence is up to 30% of patients on heparin. Type 1 HIT rarely has clinical significance. There are no bleeding or thrombotic complications. Type 1 HIT is not immune-mediated. It is caused by passive heparin binding to platelets, causing modest shortening of platelet lifespan. Type 1 HIT is managed expectantly, but there is a need to monitor type 2 HIT in case it occurs. Type 2 HIT. There is severe thrombocytopenia with thrombotic complications. Platelet count reduces by more than 50% or reduces to lowest 50 times 10 to the power of 9 per liter. Half of these patients develop serious thrombosis after the platelet count starts to fall. Mortality is high, mainly from pulmonary embolus. In addition, 20% gets arterial thrombosis, leading to stroke and limb ischemia. Type 2 HIT occurs if heparin use is more than 5 days and typically occurs 4 to 14 days after starting heparin. Incidence is 1 to 6%. Mortality is high at 20%. Heparin exposure induces formation of pathogenic IgG against platelet factor 4 on platelet surfaces, and this causes platelet activation and DIVC. 50% are at risk of major thrombotic events such as arterial or venous thromboembolism. There is also risk of major bleeding such as hemorrhagic stroke and classic bilateral adrenal hemorrhage. Diagnosis may be via the 4T score, which consists of several categories such as thrombocytopenia, timing of platelet count fall, thrombosis or other sequelae, and other causes of thrombocytopenia. If total points are 6 to 8 points, there is 64% probability of HIT. If it's 3 or less points, there is low probability of HIT, less than 1% in meta-analysis. Another method to diagnose type 2 HIT is via heparin PF4 assay. Treatment is to stop heparin, avoid platelet transfusion, monitor for thrombosis, use of alternate anticoagulants such as fondaparinux or lepirudin, and not to start warfarin due to risk of skin necrosis and limb gangrene. Other side effects of heparin include hypotension, which may occur following rapid IV administration due to vasodilation and venodilation, hypersensitivity, hyperkalemia due to inhibition of aldosterone secretion, heparin rebound after protamine reversal, also known as rebound hypercoagulopathy, especially after cardiac bypass. This is due to heparin absorption and later release from extravascular tissues, rapid clearance of protamine, which exceeds clearance of heparin, and binding of protamine to fibrinogen, reducing circulating protamine. Other side effects of heparin include hepatotoxicity, skin necrosis, osteoporosis due to complexing of mineral substances from bone. This occurs with prolonged use. Alopecia also occurs with prolonged use. Other problems with heparin: narrow therapeutic index. There is a need for monitoring of APTT, aim 1.5 to 2.5 times baseline. This is for unfractionated heparin. Routine monitoring is not necessary for low molecular weight heparin and fondaparinux. Variable effect of unfractionated heparin is due to variable plasma protein concentrations, zero-order kinetics at high dose, variable elimination rate by metabolism more than excretion. Heparin resistance may occur due to variation in concentrations of heparin-binding proteins, increased heparin clearance, such as in splenomegaly during liver disease, or due to reduced AT3 availability, such as in DIVC, use of bypass circuit, nephrosis, or congenital deficiency. Treat with AT3 or FFP. B. Briefly explain how protamine reverses heparin and list its side effects. Draw a log dose response curve of heparin in the presence of protamine. Mechanism of action of protamine. Protamine is a mixture of low molecular weight cationic basic proteins prepared from the sperm of salmon or other fish. Protamine is a highly basic cationic protein that acts as a reversal agent to heparin by combining with anionic acidic heparin to form an inactive stable salt solution, which is cleared by the reticuloendothelial system. Thus, protamine indirectly restores the activity of factor 2A, 10A, 7A, 9A, 11A, and 12A. 1 mg IV protamine neutralizes 100 units of heparin if given within 15 minutes of the latter's administration. Less is required after longer intervals. Side effects of protamine: inconsistent reversal of factor 10A inhibition due to inability to neutralize low molecular weight heparins well, reheparinization due to shorter half-life of protamine versus heparin, bleeding due to anticoagulant effects when protamine is given in large doses via inhibition of formation and action of thromboplastin, and interactions with platelets and fibrinogen. Other side effects of protamine includes myocardial depression, hypotension if rapid infusion, histamine release, bradycardia, pulmonary hypertension due to complement activation and thromboxane release, non-cardiogenic pulmonary edema, dyspnea, flushing, and allergic reactions and anaphylaxis. Chronic exposure in diabetics, as protamine is used in the preparation of protamine zinc insulin, previous vasectomy, or allergy to fish may predispose to allergic reactions towards protamine. The log dose response curve in the presence of protamine. The relationship between protamine and heparin is described as non-competitive, irreversible antagonism. In the presence of non-competitive inhibitor, the log dose curve is not shifted to the right, but the maximum obtainable response is reduced. Kd, the dissociation constant, is unaltered in the presence of protamine.